I'm Maina Kava. I'm a pediatric neurologist at Perth Children's Hospital and also a metabolic physician. So since November 2017, we've been running a neurometabolic clinic, which is one of its kind in Australia, catering to the needs of children with metabolic disorders who also have neurological problems or issues. And we find that many of, in fact, more than 50% of the patients in this clinic have mitochondrial disease. So it is a very well-run multidisciplinary clinic, which is supported by dietitians, nurses, social workers, and obviously with the clinical support as well. So looking at, where are the mitochondria present? So they're essentially present top to toe, every single cell, every single organ. But the most common presentation is with muscles. And this can be very, very subtle. So in fact, it may be so subtle that we've had a child who presented with difficulty in just, getting tired, fatigue, and it was labeled as a functional neurological disorder, like pseudo, basically it's like there's no organic etiology for this, and the child was making up these things. She was 13 when she presented to the emergency department and had vague presentations, just mainly with exercise intolerance, not able to wake up, fully energized, having trouble staying at school for 6 hours and getting really exhausted. And no etiology was found because at the time when she was actually investigated, she was well rested. And that's one of the things to expect. If you are suspecting mitochondrial disease, you actually have to go through a little bit of stress, which could be in exercise, and then do those blood tests. So what are the muscle presentations? So in general, just diffuse muscle weakness, not able to exercise as much as your friends or peers in school can do. And face is a muscle. So you get facial muscles. You can see that it's an important marker. When you see children with mitochondrial disease, the way the energetic look on the face, that can go away quickly. So they start off with smiling, happy faces, and then gradually, as the day progresses, by the end of school, they have ptosis, which is droopy eyes, and not able to smile as enthusiastically or energetically. They're feeling happy inside, but the energy is not there. And this can also be misdiagnosed as depression and again, functional neurological disorder. So very important to identify these symptoms in children. Occasionally, the muscle weakness can be so severe. For example, if a child has mitochondrial disease but elects to go for cross country or some athletics carnival, they continue to exercise in spite of feeling tired. They can actually end up destroying or damaging their muscles, and that process is called as rhabdomyolysis, where there is a breakage of the muscle cells. This can be diagnosed clinically as well as by blood test in which the creatine kinase, which is a muscle protein, is elevated. And also one of the important markers is what we do in clinical practice is electromyography. So I use EMG as an extension of clinical examination. And it's a simple procedure where we put a needle into the muscles, and it's the electrical activities recorded on the computers. And that gives us an idea about the muscle fibers, the motor unit potentials in the muscle fibers, and if there's any myopathy. So the next, obviously, important organ is brain. And working in neurology, I've seen a range of presentations with neurological involvement. It could be something as simple as just simple learning difficulties at school, which may be related to to fatigue and lack of energy. But it could also be directly because of the impact of mitochondrial gene mutation affecting intellectual function. So there's a range, just mild learning difficulty, which may be very difficult to pick up and may need extensive neurocognitive workup, to severe intellectual disability. The other common presentation is a child seems to be functioning okay when they are younger because they get the rest that they need, they get the food that they need. And gradually, as they're growing older, they are exercising longer, they're not eating as well or become fussy with food, and you start seeing regression of skills. So neuroregression or lack of progression of neurological skills in children is an important marker and which needs to be investigated further. Sometimes you can have very discrete presentations depending upon the genetic mutations. You can have episodes which present like stroke or acute neurological dysfunction. And this could be just sometimes very transient. Very briefly, the child may lose function of one side of the body and then recovers quickly within a few minutes. And these are called stroke-like episodes. They're not actually stroke, but they fit in the category of metabolic stroke. And that's again very important to identify because this can recur, and recurrent strokes are not good for the brain. They can lead to permanent neurological disability. Interestingly, you may not have thought, but migraines are an important presenting feature of mitochondrial dysfunction. So if we can eliminate general triggers like dehydration, not drinking enough water, what's needed for the child, or dehydration is the most common cause of headaches in children. So we always make sure that they're drinking enough water. But so ruling that out, making sure the child is not missing a breakfast or not suffering from low sugars because of lack of a good diet, and other triggers like screen time. So exclude all this. And if a child still has migraines persistently, especially if it looks like it's cyclical or related to exercise or any other physical activity, think of mitochondrial. Important to rule that out. Seizures can be an important manifestation of mitochondrial disease. Again, the seizure pattern may vary. It might be as simple as just a blank seizure to a full-on generalized tonic-clonic seizure. Again, it doesn't matter what seizure type you have. In fact, 30 to 40% of children with mitochondrial diseases may have seizures, and it's important to identify that. Myoclonus, it's a very important type of seizure activity, which may sometimes be generated from the brain, but sometimes it might be spinal, so subcortical. And it is just like a sudden jerky movement of the arm. It's an important clue to mitochondrial, particularly if it happens in early infancy or neonates. Blindness or visual impairment, again, it's something very, very important. Sometimes the presentation may be very subtle, just night blindness. The child may be able to see completely fine during the daytime and has trouble with night vision. It might be because of retinitis pigmentosa, which is pigmentation in the back of the eye, which is the fundus. And early identification is really important to prevent progressive visual impairment. And what I mentioned is pyramidal and extrapyramidal signs. Basically, these are what we find on examination. There might be subtle stiffness in the arms or the legs, and that is a sign of dystonia or spasticity. Again, if we don't have any other unifying diagnosis, I always encourage looking for mitochondrial dysfunction. Essentially, what we have heard is that it is a multisystem disease, and it can affect any system in the body without any. It has predilection for the brain and the muscle, but essentially it's a multisystem disease. All right, so if we can stop recording now. Evaluation. What to expect with once your child is diagnosed with mitochondrial disease? Expect a full, complete systemic evaluation, a head-to-toe examination, making sure all organs have been looked at. There are a lot of tests, and I won't go into the details, but I think something very simple is a blood test, which will look at creatine kinase, muscle activity, and leading up to severe invasive tests like skin biopsy and muscle biopsy, which may be required to make a diagnosis. A lot of abnormalities in metabolites in the blood and in the urine. Again, long names, some of them not relevant. You don't really need to know what it means, but these are all markers of mitochondrial dysfunction. And again, histology, like the slides that I've shown, there could be abnormal fibers on muscle biopsy. And what Richard mentioned was skin fibroblasts. Very important. If you don't get the muscle, at least if you can get the skin biopsy, get the fibroblasts, and that would help in not only looking at your mutations, but also further studies for enzyme activity and genetic studies. So to conclude, what you've probably heard since morning is that mitochondrial diseases have a variable phenotype and a high degree of suspicion is required. There might be multiple investigations required, and some of them include invasive tests. Important to ask your local physicians if there are any research studies that are going on in which the child can be enrolled. And obviously what I do for my patients is to have an emergency plan, which is individualized to their diagnosis, so that they have a management plan in case they have present in an acute metabolic crisis. So far, we don't have any definite treatment for one unifying treatment for every mitochondrial disease. There's no cure as such, but a trial of antioxidants is warranted. And obviously, I would encourage regular review with your physicians.